السلام عليكم ورحمة الله وبركاته. طلاب المرحلة الخامسة. We will continue our lecture in rheumatology. Today the subject is crystal arthropathy or crystal induced joint injury. In the body there are a lot of normally found crystals that can precipitate within the joint and synovial fluid and induce joint injury and inflammation. This is called crystal-induced arthritis. So what is a crystal-induced arthritis or arthropathy? It is a type of inflammatory arthritis caused by deposition of a crystal in and around the joint that lead to acute inflammation. And in some cases, when the acute inflammation is recurrent, it can lead to chronic type of arthropathy. Crystal can be the primary pathogen itself. I mean, it can induce joint injury in previously normal joints, or it could be only accessory factor, like in case of calcium pyrophosphate crystal, where usually precipitate and induce joint injury in previously injured joints. So there are many types of crystal-induced arthropathy. We will talk about the most common types and most important type. First of all is gout. Few points about gout. Gout is the most common inflammatory arthritis in men and both menopausal women. Of all types of inflammatory arthritis, gout is the most common. The crystal responsible for the development of gout is monosodium urate monohydrate, which usually precipitate within the joint and synovial fluid and lead to induce or induction of inflammation. Gout has male predominance with male to female ratio about 5:1, and it's usually more common with advanced age and increase in frequency over age. Another factor that increases the likelihood of development of gout is serum uric acid level. As we say, it is caused by monosodium urate. So uric acid level is main predictor for development of gout in addition to age. But most importantly, although hyperuricemia is a strong factor for development of gout, only minority of hyperuricemic individual will develop gout. So not every patient presented with hyperuricemia or high uric acid level need treatment with uric acid lowering agent. This is very important to note. So our main object is uric acid. How to deal with uric acid? First of all, few physiological points. Uric acid within the body is maintained within strict limits by a balance between intake and output of uric acid. The main source for uric acid came from either dietary intake, which is responsible for approximately 400 mg a day, and endogenous production of purine, which about 800, meaning 1/3 of uric acid came from eating or intakes, 2/3 endogenously produced by the body. These result in the production of hypoxanthine. By the action of enzyme hypoxanthine oxidase, hypoxanthine will be converted into xanthine, and another oxidase will be produce uric acid with a total amount of 1200, 800, 400, 1000. Now, in order to maintain body uric acid in strict level, the body needs to get rid of this extra amount of uric acid. How we get rid of this uric acid? 1/3 of this amount will be excreted via the gut or bowel, while 2/3 in the kidney. So if we look accurately to this diagram, we will find that in order to get high uric acid and development of gout, either one has high intake of purine or there is increased production of purine within the body, or there is under excretion of purine. This is number one. Number two, treatments available nowadays to treat uric acid will direct it against this pathway. So to decrease uric acid level, we can inhibit enzyme xanthine oxidase. So there is a group of a drug called xanthine oxidase inhibitor with the prototype allopurinol or febuxostat. Or we can increase the excretion of uric acid via the kidney by uricose uric agents, or in certain types of mammals or animals there is an enzyme called uricase. Uricase has the ability to convert uric acid into a more soluble compound allantoin, which prevent precipitation of uric acid. So the third group of drugs nowadays use is pegluticase, which is synthetic uricase that has the ability to convert uric acid to allantoin, which is more soluble, so decrease precipitation of uric acid. What are the causes of hyperuricemia? We discussed previously in general, so it is one of three major groups: either increasing intake, increase intake of food rich in purine and uric acid like seafoods, red meats, or there is increased production of uric acid and xanthine, like in myeloproliferative disorder and lymphoproliferative disorder, when there is increased cell turnover, so there is more production of purine. The same rule applies for psoriasis and certain inherited disorder like Lesch-Nyhan syndrome, where there is enzymatic defect and there is more production of purine. Finally, if there is decreased excretion by the kidney, which is responsible for excretion of 2/3 daily of the total amount of uric acid needed to be excreted. So, in patients with renal failure, in patients with lead toxicity, lactic acidosis, and a lot of drug and toxin can decrease renal excretion of uric acid, like alcohol, thiazide and loop diuretic, aspirin, even in a small dose, cyclosporine and pyrazinamide. How patients with gout are presented to us? Usually, gout presented as acute presentation with acute monoarthritis, single arthritis, single joint arthritis, like this. This is obvious. This is the first metatarsophalangeal joint. We see obviously there is redness, swelling, and the patient presented with extreme pain over the joint. This is a classic presentation of gout. This site is the most common site involved by acute monoarthritis gout, which affect more than 50% of all total cases of acute gout. Simultaneous polyarticular joint is unlikely in gout, so the majority presented with acute single joint involvement. Other common site of involvement of gout including the ankle, knee, small joints of the hand, wrist, and elbow. Axial, skeleton, or spine are rarely involved. The arthritis, as we see in here, has specific features needed to be noted. First of all, it is rapid onset, reaching maximum intensity within a few hours, within 2, 3, 6 hours. And it is so acute that usually awake the patient from the sleep at night or early morning. The pain is so severe, often described by the patient as a worst pain ever he felt. And on examination, there is maximum tenderness, and the patient is unable even to wear a sock or shoes, or even to let bedding rest on the joint. And there is also marked swelling, redness, and the skin, because of stretching and redness, it will be shiny skin. If If left untreated, the condition is self-limited and usually inflammation will subside within 5 to 14 days with complete resolution. Now, a few points need to be remembered about gout. If recurrent attack of acute gout occur in the same joint over time, it can lead to chronic gout or chronic deforming arthritis. So in patients with uncontrolled hyperuricemia who suffer multiple attacks of acute gout, it may lead to chronic gout. In this condition, where crystal can deposit in the joint and soft tissue, it will lead to formation of irregular firm mass or nodule. We call it tophi. This joint has chronic gout, and chronic precipitation of uric acid lead to formation of solid mass or firm mass, which is accumulation of uric acid. It is called tophi or chronic tophaceous gout. Sometimes these tophi can ulcerate, discharging white gritty material or even become infected. It usually indicates long-standing gout. This is next note need to be noted. Chronic hyperuricemia lead to a chronic hyperexcretion of uric acid via the kidney, and sometimes these lead to renal stone formation, and if severe enough it can even lead to renal impairment because of the deposition of crystal in the interstitium and leading to interstitial nephritis. Finally, acute gout arthritis. The main differential diagnosis including septic arthritis, other crystal arthropathy like pseudogout, or reactive arthritis. These need to be considered, but most importantly we need first to exclude septic arthritis or infective joint arthritis. This is another type of deforming tophaceous gout. We see these masses, which is the uric acid precipitated within the joint and around the soft tissue of the joint. How we investigate patient with acute gout? First and for all, the most important is joint aspiration. Any acute arthritis, joint aspiration and fluid analysis is the most important step. Looking for, number one, height white BC and neutrophil predominance, which means there is infection or inflammation. But if white BC more than 50,000 per cubic millimeter, it's more likely to be in septic arthritis or infective joint than gout. So white BC count on neutrophil is important. Under polarized microscope, we need to examine the fluid looking for needle shape intracellular and extracellular negatively charged uric crystal, which usually seen in 85% of patients with gout. Now, another investigation need to be sent is to look for underlying cause. What is the cause of gout? So we need to do renal function and electrolyte, serum uric acid, but as we said previously, normal result does not exclude diagnosis in acute gout. Markers of acute inflammation like C-reactive protein, ESR, and finally X-ray of the joint, and we see later what is the importance of X-ray in patients with acute gout. Management. Our approach in the management of gout will be divided into two pathways. First is how to treat acute attack of gout, and second is to prevent further acute attack in the future. So, management of acute attack, we have several drugs, mainly anti-inflammatory, used to treat acute gout attack. Most importantly is oral colchicine in a dose of 0.5 milligram, can be applied 2 to 3 times daily. It's the treatment of choice unless there is contraindication. And you need to keep in your mind that the main side effect of colchicine is nausea, vomiting, and diarrhea, especially in elderly population. If there is any contraindication or intolerance to colchicine, next step in the treatment is non-steroidal anti-inflammatory drug but these are less preferable because many patients who develop gout already have a lot of cardiovascular and renal disease that preclude non-steroidal for use. Steroid can be used and can be applied orally or injectable, especially in patients with contraindication to other medication. Finally, for symptomatic relief, joint aspiration can give pain relief, particularly if large joint effusion is present. This about acute attack. So, what about prophylactic or prevention of further attack in the future? Is every patient with acute attack need to take prophylactic therapy? No, there are specific indications for starting prophylactic regime. These include: number one, if a patient has 2 attacks of acute gouty arthritis within 1 year, so we need to start him. Any patient with tophi or tophaceous gout, any patient who has renal impairment caused by gout, or any patient with recurrent uric acid renal stone, or finally if there is evidence of bone or joint damage by imaging. So that is why we need X-ray of the affected joint. What agent can be used in prophylactic or prevent recurrent attack? There are 3 major groups we discussed previously in this diagram. So first group, which act on xanthine oxidase enzyme, which inhibit the formation of uric acid. We have allopurinol and febuxostat. So first group is xanthine oxidase inhibitor, which reduce the conversion of hypoxanthine to uric acid. When this drug started initially, studies show that in the early days of starting this treatment, when there is rapid decrease in uric acid, there will be flare-up of gout. So this agent, in order to be used, it should be under the cover of anti-inflammatory drug like colchicine or non-steroidal for first few months to prevent flare-up, and then we will discontinue anti-inflammatory drug, and allopurinol and febuxostat can be used usually indefinitely. Another group of drug is uric acid drug, which increase excretion of uric acid via the kidney. But in order to work properly, this drug need good renal function. So if patient presented with renal failure, this drug cannot be used. The prototype of this group of drug is probenecid, which nowadays seldomly used in routine clinical practice because of side effects and because there is much better choices. Finally, biological agents, which used to convert uric acid to more soluble compound allantoin. We said it is enzyme normally present in many mammals and animals called uricase, but we've been able to produce a synthetic analog called bigluticase, which is more potent than other drugs and usually keep to treat patients with severe disease. So bigluticase is indicated for treatment of more severe disease like tophaceous gout, or in patients with resistant or intolerable to other medication. Main side effects of this group include infusion reaction, allergic reaction, and another factor need to be considered: a prolonged use of these agents, the body will produce antibody and this drug will be lost its action. Another types of crystal-induced erythropathy is pseudogout. It's a condition associated with deposition of calcium pyrophosphate dehydrate crystal. So instead of monosodium urate monohydrate, which leading to gout, in pseudogout there is calcium pyrophosphate dehydrate. It is rare under 55 and increasing with age, so age is important. As for gout, for pseudogout to affect the joint, usually patient has underlying clinical illness. Chronic clinical illness lead to precipitation of calcium pyrophosphate within the joint, or the joint previously damaged either by trauma, surgery, or infection previously. The most common joint involved in pseudogout is the knee, followed by the wrist or the pelvis. This is in contrast to gout, where first metatarsopharyngeal joint is the most common joint to be affected. What are the causes or risk factor for pseudogout or calcium deposition within the joint and articular surface, chondrocalcinosis? First of is age. We said it is rare under 55. Osteoarthritis, meaning there is underlying joint injury. And primary hyperparathyroidism, meaning high calcium level. Rare but need to be looked for causes include hemochromatosis, Wilson disease, hypomagnesemia, hypophosphatemia. How patient with pseudogout to present? Typically, the patient presented with monoarthritis, inflammatory monoarthritis, and patient present with swelling, tender joint, and on examination there is redness, warm, and swelling, effusion. Usually, a joint has a previous history of trauma, surgery, or infection. The main differential diagnosis need to be kept in mind is septic arthritis. Always, when there is an inflammatory monoarthritis, the first thing need to be excluded is septic arthritis, followed by gout, another differential diagnosis. In some patients, the deposition of calcium pyrophosphate occurs slowly and over long period of time. These lead to development of a chronic condition called chronic calcium deposition erythropathy. So, pseudogout is acute calcium deposition, while chronic erythropathy of calcium pyrophosphate deposition is the chronic case which could occur when the joint has a previous attack of pseudogout. In a chronic state, the presentation usually presented with chronic mild pain, early morning stiffness in the affected joint, sometimes even lead to functional impairment. If patient has a chronic attack, sometimes can have superimposed acute attack. The same joints affected by acute can be affected with a chronic illness. Investigation, majority of investigation, especially the aspiration, is typical to that of gout. So, first of all, we need to do joint aspiration, and our aim to exclude septic arthritis. So, we're looking for white BC count, neutrophil predominance, gram stain, and culture of the synovial fluid. Second, under polarized microscope, we look for calcium pyrophosphate crystal, which look under polarized microscope as weakly positive charge rhomboid-shaped crystal. X-ray of the affected joints. This is the knee joint. We see these are synovial fluid and synovial membrane, usually clear space, but in here there is whitening. This whitening is calcium deposition within the synovial membrane. This is called chondrocalcinosis, which is the main imaging finding in patient with pseudogout or chronic calcium pyrophosphate deposit crystal. How we manage patient with pseudogout? Management is typical to that of gout also. So, if patient is severe pain and the joint swelling is maximum, joint aspiration for relief of a pressure is very important for relieving of pain. Next, colchicine, non-steroidal or steroid can be used in same manner that used in patient with gout. In patient with chronic erythropathy, we need to look and treat underlying cause that lead to chronic illness. But majority of patients we treat symptomatically as if patient has osteoarthritis.